Thank you. I'm wearing my clinical geneticist hat, not my biochemical geneticist hat right now. I'm going to talk about some common physical findings that those of you who are pediatricians or family physicians might see in your own clinics who that in fact might have some potential implications for diagnosis in your patients. The title that was suggested to me was A Wolf in Sheep's Clothing, Common Findings That Might Indicate a Serious Disease. Now, a couple things. One is that I do some consulting for the Virginia Department of Health, and we do have registries with a couple of the companies that are represented today, but that does not exactly impact on the talk I'm going to give you today. Now, a couple things that are fairly obvious. We all look a little bit different, otherwise you'll look just like I do, which is either going to be a good thing or a bad thing, depending on what you think about me. But most of these differences that we have, in fact, are not medically significant, and even minor anomalies or minor birth defects are generally isolated findings and are usually not a part of any underlying genetic disease or underlying malformation syndrome. So if you have a child or see a child in your clinic, or have a next door neighbor or a niece or nephew or whatever who has a minor anomaly, chances are pretty good that that's what it is and nothing else. But there are always possibilities that it might be related to something else. Your most important tool are the good old-fashioned tools of visual assessments, measuring devices, and charts to plot those measurements on. Growth charts and, of course, family histories are helpful. Now, here's a child you might be seeing in your clinic. May or may not have strabismus. I won't ask for a show of hands here, but some people might say that this child, in fact, has strabismus, that is, eye muscle imbalance. All right, well, why is strabismus important? Well, first of all, it's relatively common in the general population. Untreated strabismus might result in amblyopia, so-called lazy eye, and in fact, potentially could lead to vision loss, but of probably greater medical importance, not that vision loss and amblyopia isn't important, but sometimes strabismus can be the first sign of things like retinoblastoma or optic atrophy or cataracts or maybe even cerebral palsy. Over half of the kids with cerebral palsy have some degree of strabismus. Things like brain tumors or neurodegenerative diseases can sometimes present with strabismus as a major finding. So, does this child have strabismus or what is called pseudostrabismus? Well, the vote is, I'll tell you in a minute. How about this other child here? Strabismus or pseudostrabismus? Turns out the first one has what's called pseudostrabismus, and that's important to know, and our local ophthalmologist should probably take me out to dinner because I refer patients to them all the time whom I think might have strabismus who turn out to have pseudostrabismus, mostly because I, as a pediatrician and medical geneticists, don't want to miss something that's significant about the eyes. Turns out that pseudostrabismus, though, is really an optical illusion where you've got substantial epicanthal folds, and it makes it look as if, in this child's case, the right eye is turned inward when in fact it's not. The way that you can tell it's not strabismus, the easy, cheap way to do it, is to look at the light reflected off of the child's pupils. If you look at the child's pupils, you will see that the light reflected is absolutely midpoint in both of them, which implies that in all likelihood this child's eye muscles are in fact imbalanced. The child probably does not have strabismus. Now, that second child I showed you, the child on the upper left as you're looking at the screen, in fact does have strabismus. You can see where the light reflects off of that child's eyes are on that child's left eye or on the left side as you're looking at it, the child's right eye. You can see that one's midpoint, but you can see it's a bit askew on the other eye. So this child really does have eye muscle imbalance. The other child, the little girl with the bow in her hair, probably does not have strabismus. That light reflexes in the same spot. So a fairly easy thing to do in clinic to help you decide if a child really needs to be referred. Now, the other eye muscle imbalance, another form of strabismus, is exotropia, and that is having an eye that drifts laterally, and that's important because that is not nearly as common as esotropia, and it after 4 months of age is abnormal and absolutely needs to be referred to an ophthalmologist for evaluation, and it might indicate a neurological abnormality in that particular child. Now, this is a relatively common physical finding. It's one of the few genetic things that anybody learns about in medical school, unfortunately. I was amazed when I was a medical student how little genetics we had in medical school. We have more now, but it certainly is not proportionate to the amount of new genetic information that's out there, which I think is unfortunate. But anyway, this child has a hyperpigmented macule and really doesn't have any skin findings. Now remember that there are hyperpigmented macules, then there are multiple hyperpigmented macules. Having one or two hyperpigmented macules is not at all unusual in the general population. Turns out that having more than one or two is not all that rare either, and there are a bunch of different conditions that go along with it. The one condition that all medical students learn about is neurofibromatosis type 1. Turns out though that you can see some hyperpigmented macules in other situations like Russell-Silver syndrome, Fanconi anemia, polyostotic fibrous dysplasia, or McEwen-Albright syndrome. There are some patients with some of the forms of Lynch syndrome can have hyperpigmented macules. There's a condition called Legius syndrome that is very closely related to neurofibromatosis in terms of its pathway. Then a number of other conditions where hyperpigmented macules can in fact be seen. So just having hyperpigmented macules proper doesn't mean that you have neurofibromatosis. Obviously you want to think about that, but you need other things. Turns out to have neurofibromatosis, you have to have enough findings. And the old NIH criteria, and I think these are probably still valid, except there are a couple of conditions that in some situations fulfill these criteria. You have to have multiple hyperpigmented macules, and or at least 2 neurofibromata or 1 good plexiform neurofibroma, et cetera, et cetera. The ringer in all this stuff, though, is that these findings may not be present in that amount in young children. And that's a real problem, because if you're seeing a pediatric patient who's got a couple of hyperpigmented macules and the parents are concerned because they Googled it and they found out that the child could have neurofibromatosis, you won't be able to make that diagnosis on the basis of 2 hyperpigmented macules in a young child, but you also can't totally exclude that. And this is from an article that was about 14 years old now, but it's still pretty good. Talks about the order of appearance of these different findings in neurofibromatosis type 1. Turns out hyperpigmented macules are usually present by 1 year of age. Axillary freckling, which we used to think was specific for neurofibromatosis, it turns out it is not. Lish nodules, those little brown spots on the iris, may not show up until around 8 years of age, and then real live neurofibromas aren't terribly common before puberty. So absence of these other findings does not let you off the hook in a young infant who has hyperpigmented macules. Turns out that about half the cases of neurofibromatosis type 1, so the absence of a family history is not particularly helpful. And it turns out that if you have sporadic neurofibromatosis type 1, about half of those patients don't meet those NIH criteria that I mentioned earlier. So the important thing about those patients is that you have to follow them up. Okay, what do we do in clinic? We tell the patient, well, we don't have criteria to make the diagnosis, but we want to continue to follow your child. And we probably have ophthalmology evaluate them, et cetera, to make sure they don't have evidence of optic gliomas, et cetera. And it turns out that about almost 100% of the patients met criteria by age 8 years, and in this particular study, 100% by age 20 years. Now, again, I mentioned hyperpigmented macules. Most of us learned the term cafe au lait spots, but remember, that only works if you're a white French guy. It's darker than you are. So if you are a white French guy, then it's cafe au lait. If you are someone from Nigeria with very, very dark background pigmentation, it's darker than you are. And sometimes the dark spots in someone with very dark skin color are difficult to see without a UV lamp, just like the light-colored spots in a patient with tuberous sclerosis are difficult to see in a light-skinned Caucasian person. Okay, now I'm going to tell you about a 12-year-old girl with short stature. She showed up in the office. She's below the 3rd percentile, unremarkable physical exam. Her height is 4 standard deviations below the mean, no obvious physical abnormalities. She's 12, but she has Tanner stage 1 breast, which means no areolar development at all, no pubic hair, and you do a lymphocyte karyotype, and she has Turner syndrome. She is missing one of her 2 X chromosomes. Turns out that Turner syndrome is not all that rare. Most girls with Turner syndrome are below the 3rd percentile at birth. Okay, so if you have a small girl, doesn't mean she has to have a karyotype, but just keep that in the back of your mind. And it turns out that not everybody with Turner syndrome has the classic findings of the web neck and the hyperconvex nails, et cetera, that we know to associate with that. But by age 10 years of age, virtually all girls with Turner syndrome are below the 3rd percentile. So you need to think about Turner syndrome if you've got a child, a girl, with web neck and or peripheral edema at any age. If you've got any female patient with coarctation of the aorta, about 20% or so of girls with Turner syndrome will in fact have coarctation. If you have a girl with short stature and a girl with delayed puberty, particularly with short stature. But remember that most short girls do not have Turner syndrome. By definition, 3% of the population is below the 3rd percentile. Okay, and most of those patients do not have a specific underlying genetic diagnosis. Okay, here's a boy with tall stature. Normal IQ, has increased arm span relative to height, has decreased upper-lower segment ratio, that is, his legs are disproportionately long relative to his trunk. He does have cutaneous stria on his lower back, and you take a family history and it's really pretty unremarkable. Turns out that there is a differential diagnosis of tall stature, and most tall people are what I refer to as normal tall, okay? That means they're tall, and they don't have any specific genetic reason for it that we can define in a laboratory. Turns out that many patients who have exogenous obesity tend to be above average in height, if not abnormally tall. Patients, the things that we all learned about in medical school, things like Marfan syndrome can be associated with it, Klinefelter syndrome, XYY, et cetera. Some connective tissue disorder. So if you see a tall patient, doesn't mean you necessarily have to work them up for all these conditions, but you need to do a good physical examination and make sure that you can justify not doing additional studies to check these other things out. And this is a growth chart for somebody with, in fact, Marfan syndrome, and shown over here, and it's kind of hard to read. The letter B there is the 97th percentile for normal individuals. So you can see that the average person in this particular constellation of studies, the average person with Marfan syndrome was taller than the 97th percentile for their patient population. Again, a couple things to worry about with tall stature. One is the age of the patient and the age of onset of the tall stature. Family history. Tall family members, tall parents tend to have tall children, and most of the time that's not related to a specific underlying genetic disease. Having said that, Marfan syndrome is autosomal dominant, as are a number of the things that can look like Marfan syndrome. Obesity, as I mentioned to you, patients with exogenous obesity frequently are taller than average, if not taller than normal. The overall body habitus, evidence of connective tissue disorder, and then things like sexual maturation and intelligence. Again, most tall people do not have a syndrome, but this patient did. So because he was tall and we were a little concerned, we sent him to our friendly cardiologist, and they found a dilated aortic arch, and we sent laboratory testing for one of the panels that was offered by a laboratory who I will not name now. And they, in fact, found a mutation in the FBN1 gene, which is the gene that is abnormal in Marfan syndrome. All right, here's a 14-year-old girl with unusual fingers and toes. Okay, she was referred to us for Turner syndrome. I'll tell you the punchline, she doesn't have Turner syndrome. It has fairly striking shortening of the fourth and fifth metacarpals and third, fourth, and fifth metatarsals bilaterally. Turns out there's a differential diagnosis of patients with really short fourth metacarpals, pseudo-hypoparathyroidism, pseudo-hypoparathyroidism, Turner syndrome, Gorlin syndrome, also known as basal cell nevus syndrome, and a lot of normal people. A study was published years ago where they looked at lots of metacarpals and found about 10% of the people in their study had short metacarpals by whatever criteria they were using. Shown here at the top is a child with Turner syndrome who's got slightly short fourth and fifth metacarpals, and here's a little girl at the bottom with a chromosome abnormality who's also got slightly short fourth and fifth metacarpals. Single transverse palmar creases. Some of you may have heard the term simian crease. We have discarded that term, hopefully. Single transverse palmar creases are not specific for any particular condition. This child also has fifth finger clinodactyly, and turns out this particular child has Down syndrome, but most patients with single transverse palmar creases do not have Down syndrome. True simians actually have two palmar creases, not just one. And palmar creases are in fact determined in part by hand flexion in utero and relative length of metacarpals, and single transverse palmar creases are not pathognomonic or diagnostic of any particular condition. In fact, somebody did a study way back when, and about 1 in 75 people with a complete transverse palmar crease, that's either single or what's called a Sydney line, will in fact have Down syndrome. Most people with a complete transverse palmar crease are otherwise normal, but you need to do a good physical examination. So if you're seeing a child in your clinic or in the nursery with a single transverse palmar crease, don't run off to the cytogenetics lab, but they do a good physical examination on your patient. Final thoughts. Most minor anomalies and differences in stature or body habitus are not indicative of a malformation syndrome. They need to be evaluated in the context of other findings and of the family history. And the other thing to remember are that phenotypes, that is physical presentations, can vary dramatically over time. And the other final thought is to be really careful about pictures. Pictures in books, pictures on the internet, pictures on Google, because this either may be the only pictures that the authors have, and they may look nothing like the average patient with those conditions, but they also may be so striking that this is what the authors want you to remember, even though it is so extreme that you'll rarely see a patient like that rolling into your own clinic. And with that, I will be glad to turn this over to the next speaker, and I thank you.